What we did last week, we talked about extra heart sounds and timing. Sounds around S1, sounds around S2. The timing we're going to talk about with the murmurs is it systolic or diastolic, and then we'll subclassify. With systolic murmurs, we'll call them mid-systolic, holosystolic. Very rarely there's late systolic. But mid-systolic is a murmur like this. This is aortic valve stenosis. You can pretty much hear the first heart sound and clearly hear a second heart sound on the other side of it. The murmur rises and falls between. It's often termed a diamond-shaped murmur. And if you look at the phonocardiogram, let's see if I can stop it here. This is the phonocardiogram showing you intensity. Rises to peak intensity in mid-systole and then decays so that you can hear the second heart sound. That's a diamond-shaped murmur. I don't know what a diamond sounds like. So it's a mid-systolic murmur is the proper descriptive term. And aortic valve stenosis, or valvular or acquired aortic valve stenosis, has a very harsh or guttural quality to it. It's very impure. There are multiple frequencies. So it kind of sounds dirty. It sounds like somebody clearing their throat. It's heard best in what's called the aortic area, although not everybody knows where their aortic area is supposed to be, but mostly at the right upper sternal border, and it radiates to the apex. And you'll notice at the apex, in acquired aortic valve stenosis, the murmur sounds a little different. So sometimes you can talk yourself into thinking there's two different murmurs there. Here it's got a cooing quality to it. It's got a higher frequency. That dissociation in the way the murmur sounds like is called Gallivardin's dissociation. It's always due to calcific or acquired aortic valve stenosis. So heard with the diaphragm, right upper sternal border, radiating to the apex, and in this gentleman we'll see it radiating outward to other places as well. You hear that rough quality to it. It's almost like somebody's dragging furniture across the floor. We can still hear the murmur. It's not as loud as it was at the right upper sternal border. And one thing that's peculiar about aortic valve stenosis is bony radiation. This is very useful. We're listening on this guy's shoulder, but the clavicle is one of the most useful places to listen because a murmur radiating to your clavicle is almost always aortic valve stenosis. So if you're trying to talk yourself into mitral regurgitation because you can't tell if it's mid-systolic or holosystolic or louder at the apex or the base, you go to the clavicle. It's like your arbitration. You hear it on the clavicle and shoulder, it's aortic valve stenosis. And sometimes it's so loud that it radiates all the way out to the shoulder, or the, in this case, the elbow. I'm anatomically challenged here. So if you're attending SU while you're listening at the elbow, you can tell him I told you so. So aortic valve stenosis, high frequency, mid-systolic. You can hear S1 and S2 on either side of the murmur. Radiation to the apex, bony prominences, and also the carotids. Now, I made the distinction calcific or acquired aortic valve stenosis because, as you know, you can have a congenitally dysmorphic valve. In listening last week, we listened to the ejection sound of a bicuspid valve. Now, this young man has the typical murmur, and we'll have to seek out his ejection sound. Oh, curses. I can't navigate. What the hell? Okay. Briefly lost. Okay, now we're listening at the apex, and if you'll notice, we're listening a little bit away from the mid-clavicular line and down a little bit, suggesting that his heart's enlarged. And you can see he's got a very forceful apical impulse, which you'd expect. And the first heart sound sounds reduplicated. he's got a very short isovolumic systole. His valve is thrust open very early on, and his ejection sound's close to the first heart sound. So in this fellow, we found evidence of aortic valve stenosis, moved to the apex to find the ejection sound. And he's hungry. We didn't hear much radiation out at the apex, but here there's clear radiation above the clavicle. Now we're going to differentiate that from pulmonary valve stenosis, which is also, in its milder forms, mid-systolic and heard at the base, generally left upper sternal border. So you can still hear first heart sound. You hear the murmur kind of groan into peak intensity, very light. And we hear a second heart sound. So it meets the definition of mid-systolic. Now, pulmonary valve stenosis, unlike AS, as it gets worse and worse, the murmur actually may diminish somewhat in intensity and get longer, sound almost holosystolic. But our point of differentiation with pulmonary valve stenosis is, one, we're going to seek out a pulmonary ejection sound. Two, it's not going to radiate above the clavicle. And patients generally present with exertional fatigue, and we're going to find evidence of right ventricular hypertrophy. An RV heave or an RV tap that's palpable left of the sternal border, and we'll look for abnormal neck veins. Now, hers aren't very abnormal. But you can see here, if you watch her right above the jugular notch here, you can see the quiver of the rather brisk jugular venous A wave present due to right ventricular hypertrophy. Now, this young lady has a slightly more prominent jugular venous pulse, and in fact, you look at that and you say, well, that looks like a carotid impulse, very rapid in its upstroke. Place your fingers across the two heads of the sternocleidomastoid, you'll obliterate this impulse. Whereas if it's carotid and you press hard enough to obliterate the impulse, the patient will swing at you or pass out. And if we take this transducer and take it above the clavicle and listen onto her carotids, the murmur will not radiate upward. So we've got a mid-systolic murmur at the base that doesn't go above the clavicles. Now, aortic valve stenosis, so we talked about the two mid-systolic murmurs at the base. Aortic valve stenosis, or rather aortic stenosis, can be valvular, calcific or acquired, or bicuspid. Can be supravalvular, which is generally congenital, and can be subvalvular due to an acquired ridge or a membrane that grows in, usually patients with congenital heart disease, and can be dynamic, which is what we're going to see an example of here. So this is a subaortic stenosis that's due to left ventricular hypertrophy. This is a subaortic stenosis that's due to left ventricular hypertrophy. So listening at the apex, his first heart sound is somewhat accentuated. Don't hear much in the way of a murmur. Now we've got him in a little bit different position, and you hear this kind of squeaky, short systolic murmur. We'll have to wait for him to finish this hand grip, and I'll tell you why he's doing that. Especially right after he lets go of his hands. What happens with severe left ventricular hypertrophy or hypertrophic myopathy is that the septum grows so thick that it encroaches on the left ventricular outflow tract. The anterior leaflet of the mitral valve can't get out of the way of the flow stream. So the flow stream grabs the valve and essentially slams it shut, shutting the left ventricular outflow tract. When it does so, it shuts the left ventricular outflow tract, but now we've taken the mitral valve and shoved it over, so we create mitral regurgitation. So we have a sequence. So as we start left ventricular ejection, we have ejection, obstruction, and leak. And we can have a murmur due to the obstruction, which will give us the short, squeaky, high-frequency murmur that's usually loudest along the left sternal border. Or separately, we can have the murmur of mitral regurgitation. And in both instances, since it's a function of the amount of room we have here, if we increase left ventricular volume, just like we did with mitral prolapse, we can diminish the intensity or the onset of the murmur. What a hand grip does is increases your afterload. So you leave more blood in the ventricle. It takes longer to obstruct if it does at all. So let's listen as he goes through the sequence of hand grip and listen to what happens with the murmur. There it comes on. And it's gone. Coming back. You hear that kind of mid-systolic squeak. Now with Valsalva maneuver, we're going to do the same thing. In the strain phase of Valsalva, we're going to stop blood from coming back to the heart. So the heart's going to operate at a lower volume. We're more likely to obstruct and leak. So eject, obstruct, leak. As he releases, it'll diminish. Got a little bit of the murmur there. Really comes on. There's mitral regurgitation. And away it goes. So in here, we've got mid-systolic murmur that's generally loudest along the lower left sternal border, and we can modify it with maneuvers to make our diagnosis. Standing and squatting, the same as we did with mitral valve prolapse. When we squat, 600 cc's back to the heart. Stand, you leave it in the legs. Just the hint of the murmur is present there. There it comes on strong. Blood back to the heart goes almost completely away. So these patients generally will present with exertional dyspnea. They may pass out, sudden death, myocardial infarction with normal coronary arteries. You hear the murmur and put them through maneuvers, you've got the diagnosis. They almost always have an abnormal electrocardiogram, and you establish the diagnosis with certainty by echocardiography. Now then, continuing on our systolic murmurs, we've done the mid-systolic murmurs, aortic valve stenosis, pulmonary valve stenosis, hypertrophic cardiomyopathy. Now, mitral regurgitation differs. As soon as you hear a first heart sound, the murmur is going to reach peak intensity, and it's going to last until the second heart sound. It's going to be loudest at the apex, generally radiating into the axilla. Your timing, first and second heart sound. We're starting to hear the murmur at the lower left sternal border. High frequency, a lot more pure than aortic valve stenosis was. How many of you hear a second heart sound right after the murmur? It's a third heart sound. Let's move out a little bit. Remember, the holosystolic murmurs will encompass the first and second heart sound. We're out into the axilla. Here it's just murmur. do here is listen to those same stations and we'll inch. Get your timing up at the base. You may note that his second sound splits a little bit and his pulmonary valve closure sound is loud. We're going to move and just hear the murmur at the lower left sternal border. You'll be able to hear first and second heart sound and the murmur. And then as you move out to the apex, what sounded like a second heart sound you'll notice is low frequency, and it's almost like the ventricle's groaning. And that's an inflow rumble. So much blood has gone back into his left atrium that a lot of it's going to come back down. So he's still got a cardiac output 4.5 liters a minute, but in his side of his heart, he's got 9 liters going across that mitral valve in diastole. Okay, let's... With aortic and pulmonary valve stenosis, you can get some idea as to severity based upon the timing of peak intensity of the murmur and the time of aortic or pulmonary valve closure sound. With mitral valve regurgitation, the quality of the murmur tells you absolutely nothing about severity. However, the presence of an inflow rumble, like he has, tells you it's definitely severe. Now, as typical in medicine, any rule there is, there's always an exception. So with mitral valve regurgitation, I told you the murmur encompasses the first and second heart sound, making it holosystolic, except when it's acute. With chronic mitral regurgitation, the left atrium has grown gradually with time, so it handles all of that regurgitant blood. When it's acute, for example, after myocardial infarction, or you've got a torn chordae tendineae or endocarditis, then the left atrium is still small. So you're ejecting half of the contents from your ventricle back into the atrium, and the pressure rises rapidly, shutting off the regurgitation. So the murmur will decay through late systole and even sound mid-systolic. And you can see these patients are almost always symptomatic, severe dyspnea. Frequently they'll be intubated by the time you get to see them. Because this guy's not intubated, but as you can see, he's tachypnic. So acute severe mitral regurgitation can be tricky. Many times the murmur is only audible over the apex. It may sound very innocuous, and it sound like a short mid-systolic murmur at the apex. However, the patient's going to be acutely ill, and your clinical suspicion for acute severe MR needs to be high. The diagnosis can be established either with Swan-Ganz or right heart catheterization, or more commonly now it's with echocardiography. Now, when we were talking about the holosystolic murmur, it's loudest at the apex with radiation to the axilla. And the reason the point of maximal intensity of the murmur is important is because playing the sounds like game, you'll miss ventricular septal defect. You know, we're listening at the lower left sternal border. Ventricular septal defect sounds exactly like mitral regurgitation. The only difference is loudest along the lower left sternal border. Just like severe mitral regurgitation, VSDs can have an inflow rumble because 4 liters goes to the body, but if half of the ejected blood goes to the right ventricle, then 9 liters is going to come across your mitral valve. Now, VSDs can be congenital, and when congenital, 90% of the time they have a thrill, which is the palpable vibratory sensation. You can feel that best with a pad of your hand. So when palpating for the PMI, you can use the pad of your hand over the left sternal border to see if you feel a thrill. With acquired VSDs, like post-infarction, you're less likely to feel a thrill because the ventricle's been harmed and it's applying less force to the blood pool. Dr. Joe Perloff, who's really the father of physical diagnosis, in particular with congenital heart disease, gave a talk here several years ago. And in making the point of the thrill, he noted that in students' rounds one day, they were presenting a young lady who had a VSD. And he sat at the bedside with her in the seated position. He reached over and felt of her chest. And he remarked how odd it was that he didn't feel a thrill. Now, this netted him a complaint to the administration at UCLA. So a thrill is almost always present with congenital VSD, but not with acquired. And we're going to listen from the base and out to the apex and note the point where the murmur is loudest. So we'll point out a couple of things. Look at her precordium being thrust. You can counterpulse by watching her precordium be thrust upward. You can hear crackles. She's in pulmonary edema. Now we hear the murmur, holosystolic, high frequency. We're not quite to the apex, and it's reached its maximum intensity. And as we move more leftward, the murmur goes away. Mitral regurgitation, remember, continues into the axilla. So acquired VSDs may be loudest anywhere between the apex and the lower left sternal border. Congenital VSDs are almost always loudest right next to the sternum because they're usually perimembranous. But anywhere between the apex and the lower left sternal border, and decays, goes away in the axilla, whereas mitral regurgitation continues into the axilla. So VSDs, more common after anterior, more deadly after inferior infarct, usually show up sometime between day 3 and day 7 with either hemodynamic instability or pulmonary edema. It's why when you have someone admitted with a myocardial infarction, you have to lay your stethoscope on their chest every day. Okay. So I usually tell you, don't play the sounds like game. You know, go through the thought process. If it's an extra sound, is it around S1 or S2? Do I hear it with the bell or the apex? Or the bell or the diaphragm? Is it the apex or the base? What's associated with it? Murmurs, generally you do the same thing. Holosystolic, mid-systolic, diaphragm or bell, apex or base. What goes along with it? One murmur you can use it as exception because you can say, hey, you know what that sounds like? And that's this one, which is tricuspid valve insufficiency. Now the murmur is not particularly prominent on this part of the recording, but I'll draw your attention to her precordium. Note that the right side lifts upward during systole, the left side pulls in. This is called the contra-Q lift, or rocking precordium of tricuspid valve insufficiency. The right atrium's getting all that regurgitated blood, and it swells out. So it lifts the right chest while the right ventricle's squeezing. Then all that blood that just went to the right atrium, plus what you've got to pump out to the body, goes back into the right ventricle. So the left side pops back out. This is a diagnosis you can make from the foot of the bed. Now we're going to hear the murmur a little bit better. Note its change with her ventilatory effort, and the character of the murmur is very distinctive. It's accentuated by her ventilatory effort because of the increase in right ventricular blood volume. And it has a very distinctive character. It sounds like a honk. So she's got an abnormal mitral valve, and if I remember correctly, she had rheumatic disease. Patients who acquire mitral or tricuspid valve regurgitation due to enlarging right ventricular volume may not have the honking quality this murmur has, but they'll often have the ventilatory accentuation. However, the most striking thing about tricuspid valve insufficiency is what it does to the neck veins. I think you can see her veins a little bit better. If you look at this area right in front of your ear, starts up with the first heart sound, continues upward, and then falls rapidly at the second heart sound. So you stand at the foot of the bed, you see this large jugular venous, what's called an S wave, the systolic wave of tricuspid regurgitation. And you see the rocking precordium. You don't even need your stethoscope to make the diagnosis. If you look at her veins all the way up into her temples, these veins are throbbing. In some of these patients, the right atrial pressure will be so high you have to sit them up and use arm veins to see what the crest of the systolic wave is. Now, the presentation is usually that of right heart failure, may be solely fatigue, but they may have hepatic congestion, which may impair their appetite and give them right upper quadrant discomfort. They may have morning facial edema because of the high right atrial pressure and the fact that they're not prevented from lying flat. They're not uncomfortable lying flat, so that they'll get morning periorbital edema, may have lower extremity edema. The other point on physical exam is that this impulse is transmitted to the liver. So when you feel in the right upper quadrant, the liver is almost always enlarged and pulsatile. So you can feel each systole as you feel the liver edge. Okay, let's get beyond that. Now we're going to move to diastolic murmurs. The first one we'll do is the hardest one to hear, and that's aortic valve insufficiency. It's high frequency, 600 to 800 hertz, which is about the same as somebody whispering at you. And you know, it's a lot of times if you're trying to get somebody's attention, if you're whispering, it's hard to get their attention, especially in class if the teacher's watching. So it's a high frequency murmur that begins with a second heart sound and decays. So it's early diastolic decrescendo, and it's loudest usually on lower right or left sternal border. You may need to apply just a little bit of pressure with the phones to hear it best because of that frequency. There's a mid-systolic murmur as well because of the volume of blood that's going back across the aortic valve. In fact, it's very frequent with chronic severe aortic valve insufficiency. Your ear may pick up on the systolic murmur first. A little bit more difficult to hear. And you'll note that his aortic second sound is fairly prominent. The aortic second sound is loud. You hear a little bit of the systolic murmur, almost no diastolic murmur at his apex. And of course, in listening at his apex, we're going to seek out an ejection sound because bicuspid aortic valve is one of the possible causes of aortic valve insufficiency. Now you'll note that our transducer's out here at the anterior axillary line, and we're a couple of rib spaces low, suggesting his heart's big. And in fact, the largest left ventricular chamber you'll see is with chronic severe aortic valve insufficiency. His apical impulse is thrusting so hard that we get to see the wire move here. The reason the ventricle gets so big is it's operating on that whole volume. Remember, this ventricle is pumping 9 liters to get 4.5 to your body. Meanwhile, it's operating at systolic pressure, so it becomes very hypertrophic as well. The pathological appearance of the heart has been termed cor bovinum, or cow's heart. So much force is applied to such a large stroke volume that our transducer over the brachial artery can hear a Korotkov sound without the cuff. It's called Traub's pistol shot. Really, any source of high stroke volume will do the same thing. Hyperthyroidism, severe anemia. And one of the other classic findings is a wide pulse pressure. Does anybody know the definition of wide pulse pressure? Anyone? Bueller? Yeah, but that's where the question is. How large is large? It's like Jesse Helms, right? You know it when you see it?
I want to say above 60.
Well, it's greater than 1/2 the systolic pressure. So if you have a pulse pressure greater than 1/2 peak systolic, that's a wide pulse pressure. Now I'm going to ask you what this fellow's blood pressure is. Okay, so now listen to it again. As we go by 165, you hear the first Korotkov sound. Then it's doubled. It's Farian's pulse. And as we go about 24 here, listen to the change in character of the sound. Gets more muffled. That's where we go from the 4th to the 5th Korotkov sound. So in somebody with a very wide pulse pressure like this, we would report his blood pressure as 165/24/0, saying that we can hear 4th and 5th. The 4th sound corresponds best with arterial pressure measurements. So very wide pulse pressure, and it's unusual in a normal young man or woman with chronic severe aortic insufficiency to see a systolic blood pressure less than 160. They need that wide pulse pressure. There's so much stroke volume going out. And you give them a blood pressure lowering medicine, try to get that systolic pressure down, and down they go. Okay, now we're listening over the femoral artery. You hear systolic bruit. So much blood going out into this aorta at such rapid rate, so much force is applied to it, we're exceeding Reynolds number, and you hear a bruit without a stenosis. If you place your finger distal to the femoral artery and compress it, you'll hear bruit in diastole as well. It's called de Roget's to and fro murmur. Now there's a lot of these name signs. Most of them are completely useless, like Müller's signs. Anybody know Müller's sign? What's that? The oscillating uvula. Yeah, if you go to New England Journal's website, the best example of that I have ever seen is available on their website. It's absolutely phenomenal because she's got a really big uvula. But it's worthless diagnostically. One of the signs that is kind of useful, though, is de Musset's sign. Does anybody know de Musset's sign? I see a couple of nodding heads. Yeah. Now, de Musset's sign is interesting, one, because you can see it when the patient's sitting in the clinic. You see the nodding head. But the second thing is that it was not described to be useful for diagnosis for medical reasons. Well, I suppose it was. It was for public health reasons. De Musset described the sign in a statement made to the ladies of Paris, "Dance not with a man with a bobbing head." Now, excluding the 4th years, does anybody know why that is? What would have been a common cause for aortic valve insufficiency in 1700s France? Syphilis, yeah. What he was trying to do was stop the spread of syphilis, not diagnose aortic valve insufficiency. Okay, this guy's going to show us what can happen at the apex with chronic severe aortic valve insufficiency. Mid-systolic murmur, then then a murmur that is peak intensity at onset of the second sound and decays. Like ah, like ah. Now, if you hear the murmur at the lower left sternal border, in general, that's telling you that the valve is the source of insufficiency. Something's wrong with the valve, a bicuspid valve or endocarditis. If you hear it at the lower right sternal border, if it's loudest at the lower right sternal border, that's more commonly evidence that there's aortic enlargement that's stretching the valve, like you see in Marfan or syphilis or hypertensive heart disease or hypertensive aortic disease or atherosclerosis. You may notice this murmur has a different character to it. You can hear the second heart sound clearly, and then there's a space before the murmur really reaches peak intensity. So let's compare the two. Peak intensity with the second heart sound. Now here we're going to hear this best with a diaphragm, high frequency. At the apex, that groan you hear, best heard with the bell of your stethoscope. It sounds exactly like mitral valve stenosis. The only difference is there's no opening snap. This is the Austin-Flint rumble of chronic severe aortic valve insufficiency. You hear this rumble, you know that's chronic severe aortic valve insufficiency. Of course, you hear that rumble, then you turn your stethoscope over back to the diaphragm and go looking for that opening snap. You have to have, if there's an opening snap, then it may not be chronic severe AI, it may be mitral stenosis and aortic valve insufficiency. Okay, let's go to the next case. They're all trying to get in. One of the causes of chronic severe aortic valve insufficiency is Marfan disease. Marfan can cause myxomatous degeneration of the mitral valve and mitral regurgitation, but it also causes aortic aneurysm, and the cusps of essentially spread apart so that you develop severe aortic valve insufficiency. This fellow demonstrates many of the morphologic features of Marfan. You see he's got some glasses. They're probably very thick glasses. They're generally myopic. Their stature is unusually tall and generally thin. Wingspan exceeds height. He's going to show us his wingspan. May see pectus excavatum, more common than pectus carinatum, and we'll be able to see the impulse of his chronic severe aortic insufficiency as we get close. They may have scoliosis, spinal disease, ectopia lentis, a very high arched palate, which gives them an unusual sounding voice, and their fingers are rather long, and slightly hypermobile joints allow them to take the thumb, and when placed through the palm, it's going to stick out the other side. So let's look at each of those. So in the clinic now, I'll mark off on the wall each side here so I can measure wingspan and compare it to height. You can see his pectus excavatum, and you see it, his heart just thrusting against the chest wall down here. Now, if you do this, do it underneath here, so if it pops out, then nobody will know. Okay. Now then, the Austin-Flint rumble I told you sounds exactly like mitral stenosis, and you'll note that here. But the Austin-Flint rumble didn't have the presystolic part. This murmur says, up, up, up. You have to use the QRS here to get your timing. When that QRS pops up, this murmur stops, because your brain wants to put everything in systole. So we got low frequency. We were heard with a bell at the apex. Presystolic component. First heart sounds usually a little loud. Then we turn the stethoscope over, move inside the apex. Lift it up, lift it up. So we hear the opening snap of rheumatic mitral disease. Remember, rheumatic disease gets the leaflet tips and subvalvular apparatus and essentially sews the corner of your lip shut. So as the valve tries to open, it can't reach maximum excursion. I don't know why every Tuesday they open that door at 15 till 12. These guys get here to eat earlier than anybody. Okay. So you hear the murmurs a little bit louder, patient's heart rate's a little faster. And mitral valve stenosis does not radiate widely. You may only be able to hear it over the apical impulse. So we move inside. The A2 to OS here is much shorter. Almost sounds like a split-second sound. But we're down at the lower left sternal border to hear it. Now this is, I told you the A2OS is helpful in determining severity. Another thing that's helpful, as this patient's going to show us, is with long R to R intervals, you notice the murmur gets quiet, goes away. What that means is the atrium and ventricle are equilibrating in their pressure. And with severe mitral stenosis, that's not common. More milder forms, you may hear the murmur die off with a long R to R interval. So we move inside to hear the A2OS, and it's all day long. Da, da, da. And the only other murmur that you can play the sounds like game with is this. It's the murmur of an everted cusp of a biological prosthesis. It has a very high frequency cooing quality to it. It's systolic if the mitral valve tears, diastolic if the aortic valve tears, and you'll see what I mean. Coos at you. You can see from the phonocardiogram, reaches peak intensity right at the second heart sound, decrescendo. We're going to be able to hear it all over the chest. We need to start serving lunch later. And what's fun about it, we hear bony radiation, and it's so loud, you can really hear the vibration of the struts on these valves. It really transmits very well. It's so loud that you can hear it even at the top of his head. So an everted cusp, you say, oh, I'm never going to see that. Since we've started doing this, I've seen two. One fellow came in, and the reason he came in was he was sitting at the table having his morning coffee, and he thought his cell phone went off. He reached up for his pocket to get his cell phone, and it wasn't there. So he knew something was wrong with his valve. He had had a mitral prosthesis with an everted cusp. Okay, so that hits us for murmurs.